right. Hello, everyone. Thank you so much for joining. We will just give another minute or so for some more people to join, and then we'll go ahead and get started. All right, so it is just about the top of the hour, so I think we will go ahead and begin. So thank you so much, everyone, for joining today, and welcome to today's webinar, which is hosted by the Coalition Against Hepatitis for People of African Origin, which is also known as CHIPPO at the Hepatitis B Foundation. My name is Beatrice Sovich, and I'm a Public Health Program Manager at the Hepatitis B Foundation and manager of CHIPPO. Thank you all for tuning in today. So in honor of Liver Cancer Awareness Month this October, today's webinar is focused on gaining insights about how best to address hepatocellular carcinoma, or primary liver cancer, in settings with limited resources, particularly in sub-Saharan Africa. We will have an opportunity today to hear from two esteemed panelists who have done considerable work in this sphere in West and South Africa, and will be able to share some valuable perspectives that can hopefully have broad application. So we look forward to today's important discussion. Next slide, please. Thank you. So before we get started, I would just like to remind all webinar participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box, and we will address it as soon as possible. At any time during the discussion, you can enter questions into the Q&A box, and questions will be addressed by our panelists at the conclusion of the discussion. The session is also being recorded, and the recording will be shared with attendees following the webinar. Next slide, please. Thank you. So just a quick overview of CHIPPO. So the Coalition Against Hepatitis for People of African Origin is a community coalition that was co-founded and led by the Hepatitis B Foundation. We're composed of organizations and individuals who are interested in addressing the high rates of hepatitis B infection among African communities around the world. CHIPPO serves as a forum for sharing information and best practices and improving capacity to increase hepatitis B awareness, testing, vaccination, and treatment among highly affected African communities. We currently have over 70 coalition members from across the United States and around Africa. Next slide, please. Thank you. So today we're honored and excited to be joined by Professor Mark Sandrup and Dr. Gibril Ndao. So Professor Sandrup teaches in the Department of Medicine and oversees the Division of Hepatology at the University of Cape Town in South Africa. And Dr. Ndao leads the Hepatitis Research Group at the Gambia MRC unit at the London School of Hygiene and Tropical Medicine. They've each done extensive research and taken action steps in the area of liver cancer among African communities, and we welcome their insights about this important topic. And we're very excited to hear from Professor Sandrup and Dr. Ndao today, and are grateful to them for joining us. So without further ado, I will begin the panel discussion. And a reminder that audience members are welcome to put any questions you may have in the Q&A box throughout the discussion, and we will address these questions throughout and at the conclusion of the presentation. Thank you so much. So Shreya, if you want to stop sharing, that would be great. Thank you so much. So to start, I will just ask each of our panelists to please introduce yourself and describe the current state of hepatocellular carcinoma in your respective countries, if you don't mind. So Professor Sandrup, I will start with you.
Right. Thank you, Beatrice. And well, thank you. You've introduced me. I'm Mark Sandrup. I'm a hepatologist. I'm based in Cape Town, South Africa. And thank you very much for CHIPPO for hosting this, because I think any bit of spotlight that we can shine on what remains an absolutely devastating disease on our continent should be lauded and should be encouraged. And we want more spotlights and loud hailers around this issue so that we can start doing a lot more than what we're currently doing. So, I mean, I think you've kind of intimated, and to answer your question directly, I just want to create a bit of background. So, I mean, hepatocellular cancer remains a significant cause of morbidity and, more importantly, mortality in sub-Saharan Africa in particular, but Africa as a whole. Given the nature of the endemicity of hepatitis B in sub-Saharan Africa, followed by hepatitis C, it is one of the leading areas of hepatocellular cancer in the world. Globocan tells us that it's the third leading cause of cancer in men in Africa, fourth in women. And the reality is that we are, on all metrics, lagging very far behind in terms of our continental response to this malignancy that sadly remains underdiagnosed, and if and when diagnosed, the prognosis remaining, appallingly poor. So I'm sure my colleague Gabriel Handau will talk about his own experiences, and I'm going to then sort of funnel down on the sort of Southern African area, my own country, South Africa, and maybe just draw on some data quite close to home. But I think it's probably representative of the region as a whole. My colleague Sanju Sopnak has recently completed some work, and those of the participants who perhaps attended the Calder meeting may have heard him present some of this data and work. But we've sort of analyzed almost 700 HCC patients in our center over a period of time. And, just to indicate the factoids. And the factoids is that well in excess of half the patients have hepatitis B-related cancer. I think a major deviation from the normative approach or outcome one would see sort of globally in our center, 43% of patients, in fact, are not cirrhotic at the time of presenting with the HCC, something that, of course, is, as I said, not the case in many other parts of the world where cirrhosis is already established at the time of the HCC presenting. And that's, of course, because hepatitis B and its endemicity and its massive contribution to HCC doesn't require the presence of cirrhosis by the time you develop liver cancer. So those are broad brushstrokes. And in terms of outcome, I mean, we've got a 90-day survival rate. That's our overall median survival, 90 days. And I think if you think that sounds bad, I think wait till Gabriel shares his data with you, because it doesn't get much better. So unfortunately, we are really normative, I think, for many parts of our own region, but perhaps the continent as a whole. As I said, particularly sub-Saharan Africa. Bottom line, hepatitis B dominates. HCC is the leading cause of, so hepatitis B remains the leading cause of HCC. There are a number of other factors creeping up slowly as the years go on, and we're seeing changes in epidemiology. We probably are starting to see the influences of MASLB starting to come through, maybe as either a singular or co-factor in further augmenting risk. And that's why the tasks upon us are so important to actually start addressing so many of these issues. And outcome remains universally quite unimpressive and very poor. So it's all about prevention, 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 and that is where we really need to start. But at that point, I'm going to hand over to yourself and then on to Dr. Ndau.
Yes, thank you so much. Yeah, certainly the burden of hepatitis B is enormous on the continent, and this very sobering about the very poor prognosis for HCC. So thank you so much for sharing that. Yeah, Dr. Ndau, over to you if you'd like to provide a picture for the Gambia as well.
Yep, thank you very much, Beatrice, for the invite, and like Mark, congratulations on hosting this. We need more of these events, and I hope that we have other communities joining this webinar, and not just like the usuals, but I mean, like, we need policymakers and politicians, and other people in leadership and decision-making positions who would hear the burden and the urgent call that we need to address this huge burden of liver cancer on the continent. Like you said in your introduction, my name is Jibril. I am based in the Gambia, where I lead the hepatitis research group at the MRC unit. And I also oversee the liver clinic at the MRC unit in the Gambia. Similar to the global picture of like hepatocellular carcinoma across the continent, in the Gambia, HCC is the #1 cause of liver cancer amongst men and #3 in women. So it is a major cause of premature death. Unlike in other parts of the world, in the developed world and in Asia, where we often see HCC like later in life, in the Gambia and most of West Africa, the incidence is pretty much high in the 3rd and 4th decades of life. So very young people at their peak, at their prime, are presenting with very advanced stage liver cancers that is, like terminal with no curative options for them. Most of these, the underlying cause is usually hepatitis B. A small proportion is hepatitis C. And like Mark has started to say, we need to account for other non-communicable diseases, which we know could also contribute to this burden of liver cancer, and which are becoming more and more common on the continent now. Obesity, metabolic syndrome, type 2 diabetes, and all of those. I think data from other parts of the continent are even slightly better. In West Africa, the median survival between diagnosis of liver cancer and death is 45 days. So it's 1.5 months. So it's not even up to the 90 days that we often see in other parts of the world. And we can go into the details of why is this, but it's largely has to do with the stage at which people usually present. In our setting, most of the time, people present at a very late stage with a tumor size of more than 6 centimeters, often multiple masses in the liver with metastasis to other parts of the body. Like with very little possibilities for any intervention at that stage. So survival is very poor, prognosis is very poor. And on the one hand, like this is sad for the patients, but also on the other hand, it also feeds into the reasons why people don't often present early, because if most of the people presenting with liver cancer at hospital would die within a month or two, others with similar symptoms wouldn't turn to the hospital because they would think, oh, this is not a disease for the hospital. Let me try traditional treatment options. And this also kind of just aggravates the situation in the sense that we don't get patients coming early enough when something can be done, and it becomes a vicious cycle that we go round and round in. Yes, so by and large, this is in summary the situation for like the current state of hepatocellular carcinoma in the Gambia, but also in West Africa, in terms of what are the main contributors and how are patients presenting and what is the survival. Access to diagnosis, access to surveillance, access to curative treatment is almost non-existent. We don't have any surveillance programs. And like Mark said, even if we do have these, most of the patients with liver cancer in our setting are not following the typical path where you have advanced fibrosis, then develop cirrhosis, and then move to liver cancer. Half of our patients are developing liver cancer without any background of liver cirrhosis. And therefore, active surveillance to detect these tumors at an earlier stage where interventions are possible is optimal, is fundamental if we want to turn the tide and improve survival and outcomes of these. But also to build capacity, because it requires capacity both in terms of human resources and like infrastructure to be able to actively do these surveillance programs and to have curative treatment options for patients should we diagnose HCC at earlier stages.
Absolutely. Thank you so much for sharing that and for emphasizing, yeah, as you said, the importance of surveillance, the importance of policy and decision makers in kind of shifting the paradigm in a big way, as as is so necessary for this. And certainly prevention and early detection and starting much further down the line. So we kind of addressed, you both touched a lot on the main contributors of HCC in your different settings. Hepatitis B is an enormous burden, followed closely by Hep C, and then MASLD and other similar diseases are kind of creeping up as well. And Dr. Ndow, you touched on this a little bit, but is there any, I know you said a lot of people in their 30s and 40s and even younger are being diagnosed with this devastating condition. Is there, I'm not sure, Professor Sandrup, if you're seeing similar trends, but is there any thoughts that you have on why in Africa in particular, it seems to be affecting, I know, even young men in the United States, there's been stories of young men as even in their late teens and early 20s developing just terrible, very late stage HCC. So any thoughts on why it seems to be so much more prevalent in younger folks? And if there's any other demographic characteristics of people who are presenting with it early. I'd love to hear your thoughts on that.
Yeah, so I don't know if it was me, Beatrice. I'm just
Oh,
jumping
either
in.
of you. Yeah.
Okay, Gabriel, I'll give it a shot.
Yeah. Yes.
So just a couple of things, and I think Gabriel touched on it, but I just want to go back to just to make it very clear that globally, hepatitis B affects men more frequently than women. That's the norm in most parts of the world. There are some variances in certain countries, but as a global approach, and particularly in sub-Saharan Africa, men outnumber the number of women with chronic hepatitis B virus infection. The reasons for that, Beatrice, may require a webinar all by itself, because it's a complex issue which we don't fully understand, but has got to do with potential gender and sex issues in terms of susceptibility to the virus itself. But as I said, that requires an in-depth basic science webinar all by itself. But that's the fact. Now remember that in sub-Saharan Africa, the peak time of infection is between 6 months of age and about 5 years. And in fact, the peak comes at about 18 months, quite frankly, 1 year to 18 months, reaches a peak in and around 2 years and then starts dropping off. The next common risk approach is at least risk factor is mother to child transmission. And because of that endemicity and that massive exposure, that by the time people arrive in adulthood, they're either chronically infected or they've had previous infection that has cleared. And so that real adult to adult transmission of hepatitis B is actually genuinely infrequent. And as we know, adults who get acute hepatitis B have a fairly low propensity of developing chronicity. So I'm giving you a long-winded answer to explain why we're seeing young people with hepatocellular cancer, is because the duration of chronic infection has been a long time. So just harking back to the data I was discussing with you, our sort of median age in our B population, the HCC, is around 40, and the non-HBV population is north of 50. It's significantly younger, with an interquartile range of anywhere between 30 and 50. So as I said, the range itself reaches into very young people in their 20s and sometimes even sub that to beyond 50. So it's that duration of chronicity which gives the virus and the way it behaves, of course, in the liver a long time to really cast its shadow and its cancer effect. There are a lot of interplays and issues that, of course, modify or enhance the expression of that carcinogenicity or mutagenic risk of the virus. And we know there's things like aflatoxin and other factors, and we spoke about MASLD risk and stuff like that. But primarily, why younger people? It's because of the nature of the virus in sub-Saharan Africa. We know certain subtypes of the virus seem to have a greater propensity for HCC. And the other factor is that there's this long duration of infection. There's a thought in my head, and Gabriel, I'd like to hear your thoughts because we didn't touch on it, but we would be remiss in not mentioning it. I think the HIV pandemic has had a fairly significant influence on the natural history of Hep B in sub-Saharan Africa, in the sense of we need to look at it a couple of ways. I think there is data, and Gabriel, I'd love to hear your view on this. There is data to suggest that HIV co-infection with hepatitis B, when it comes to HCC, has perhaps an even worse outcome, potentially.
Yes.
number one. And number two, HIV itself may also, with co-infection, have
Yeah.
enhanced our mother-to-child risk as well. There's good
Yeah.
data to suggest that, we've always had this very dominant early childhood infection risk in sub-Saharan Africa. And then mother to child has been relatively much less, whereas in Southeast Asia, mother to child has traditionally dominated. HIV seems to have influenced that to some extent by raising the viral load of hepatitis B in co-infected moms, enhancing perinatal risk. So just it was in my head. I forgot to mention it, Beatrice, but I think it's an important factor given the global burden of HIV is actually in sub-Saharan Africa, quite frankly. So we mustn't forget about that. But that just explains that youth nature or the young nature of infection. It's early acquisition, long-standing infection that drives that, together then with other modifying factors, as well as the nature and subgroups of type of virus. There are other factors as well, but I think I've spoken enough, and I want to hand over to Jibril.
I mean, yeah, I think you've nicely summarized all the important risk factors and the reasons why we see HCC in the younger population in Africa. In the Gambia, we did a hepatitis B natural history study, and this was following up individuals who were known to be chronically infected in the Gambia before access to treatment was available. So, and we found a few interesting things. One was those who were infected through mother-to-child transmission, which so far in sub-Saharan Africa was considered to not be the dominant form of transmission, but rather in early childhood. But those who actually were infected through mother-to-child transmission had a higher risk of developing liver cancer. And that correlates with the data that Mark has shown that, like the longer the virus has had time, like to brew in your liver, the higher your chance of getting liver cancer in your late teens or early 20s and 30s. And the second interesting thing we found that the birth order in a family has an impact on liver cancer risks. What this means is for a mother who is hepatitis B positive, their first child has a higher risk of getting liver cancer than the second one. And the third one has an even lower risk, and it goes on like that. And we postulate that this is probably because the mother would be relatively younger by the time she gives birth to the first child. And by that age, the mother would be E antigen positive and would have high levels of viremia, which would increase the risk of mother-to-child transmission. And thereby, like the cycle just goes on and on. So these are some of the drivers as to why we get a lot of HCCs in very young individuals. It's because of the early stage at which the infection was acquired, and to some extent, the more aggressive nature of the virus during those earlier stages of life. And we've also seen in quite a few studies done across Africa that, like the viral load directly relates to the risk of liver cancer. And, at the earlier stages, levels of viremia tend to be very high. Individuals tend to be more likely to be antigen positive, and all of this increases the risk of integration of the virus into the liver genome, and like the risk of carcinogenicity.
Yeah, absolutely. Thank you so much for sharing that. That's very interesting. That makes total sense about, having a long time to sort of incubate from birth to young adulthood. And the birth order study is fascinating. I think that makes a lot of sense. Dr. Ndao, did you want to add anything to the HIV co-infection discussion as well? Any thoughts?
Yes, I mean, it's also quite interesting. And I think the HIV talk has completely dominated hepatitis B and liver cancer, that whenever it's discussed, the focus is only on HIV, and very little is talked about on what impact it has on other co-infection viruses and other diseases. But there is very clear evidence that shows that both the risk of liver disease, liver cancer, and death from hepatitis B is up to 13 times increased in the presence of HIV co-infection compared to someone who only has hepatitis B infection. So it's a clear risk factor that it drives viral replication. So the copies of viral load increase, which also means that your risk of liver disease and your risk of liver cancer all increase. It's sad that, most of the resources for intervention and doing something are directed towards HIV, and very little is done for hepatitis B. And even when there are global policies that recommend that all HIV patients need to be screened for hepatitis B co-infection, because we know that this clearly increases their risk, very little is done in terms of surveillance programs for HIV, hepatitis B co-infected individuals to detect liver cancers early. And I think this is a major pitfall that we need to address urgently. It's already identified that co-infection is an important risk factor, and resources and the guidelines are very clear that all HIV positive individuals need to be screened for hepatitis B infection, and hepatitis B patients are usually also screened for HIV before you start them on treatment, because being co-infected is an indication to start therapy irrespective of other criteria. But that's about where the recommendations end for HIV infected individuals. So there is not much, especially in the terms of like screening and surveillance programs for liver cancer for early detection, there is very little activity there. And I think that needs to be addressed urgently.
Yeah, absolutely. Yeah, there's large gaps in many recommendations, and yeah, a lot needs to change in that regard for sure. So in terms of if someone, I know you had both touched upon the very short prognosis for someone who is diagnosed with hepatocellular carcinoma. Is there, what is the usual course of action if someone were to present with HCC? Is there, I know, I don't know if there's availability of any treatments to try, or is it just kind of a dismal outlook for these individuals?
Yeah. Beatrice, I think one can look at this from two angles. You can look at it from the nihilistic angle and say, it's all bad, why bother? Or you can say, well, okay, the problem is significant. How can we try and address it in a piecemeal approach? Okay, with what we have and what one may have in front of you. Okay, so before I do that, and I'm scared we may not come back to this issue, I want to come back to the P word, which of course is prevention. And so for the reasons that Jibril just stated, because of this mother to child, because of this early childhood acquisition risk, we've got to have birth dose, universal birth dose, and 3-dose vaccination for prevention, because then you and I wouldn't even be having this discussion. Okay, so really and truly, this is about as primary healthcare as one can get. It's all about prevention. But if you are faced with patients who present, so if you look at the data that was published a few years ago by Dr. Lewis Roberts and others, looking at data from across sub-Saharan Africa, they suggested that the vast majority of patients presented with, if we're going to use a global standard, the so-called Barcelona Clinic for Liver Cancer, the BCLC staging, presented with so-called stage D, which is effectively non-curative, non-anything kind of presentation. And these are patients who really present typically with either massive multicentric hepatocellular cancer, or cancer that's already invading the portal and or hepatic veins, or metastatic disease, basically. Okay, and so you've got, there are no therapeutic options. And effectively one's dealing with best supportive care. So you're talking in the realms of palliative care, and that would apply to most parts of sub-Saharan Africa. Our own experience is about 85% of our patients are presenting either BCLC C or D, and the remainder are either BCLC 0A or B. And if you look at the BCLC grading system, then one needs to decide what you can do. But the reality, and we all know that in many of our countries, there's access to very little. So if you start from the premise that maybe the earlier you'd actually find somebody and pick them up, other words, through surveillance, their chances of at least accessing some sort of intervention that may offer them, as a hope of a curative intervention remains their best option. Now, a good curative intervention that has to be considered is, of course, surgical resection. And in the fact that many of our patients are, in fact, non-cirrhotic, it is really a viable option. So the natural response to me is you're going to say, but you need access to surgery. Well, absolutely. But my hepatobiliary colleagues have looked at this. They've looked at the presence of the availability of surgical interventions across sub-Saharan Africa. And in fact, there are centers available. There are areas available in many countries where there are surgeons that can tackle liver resection, for example. So I'm getting back to my initial point. One mustn't be nihilistic. It doesn't mean that it's there for everybody, but it is available. And maybe what we should be doing is trying to capacitate regional centers of excellence that people could be referred into. But I want to segue back to my point. That does mean you are detecting people early, because again, the vast majority are presenting very late where you can offer very little. So then we have to segue into surveillance and screening. And so unless you have some sort of option for that, then really you are backing yourself into a corner completely. And then we have to return to the nihilistic approach. But here again, we need to kind of think outside the box. So the current standard is at least 6 monthly ultrasound and an alpha-fetoprotein. Okay. That sounds very simple, but Gabriel, I think you would agree, for many people, that's simply not even available, right? So the problem is ultrasound itself is not such a difficult intervention. I'm slightly been around a bit longer, but with my residents on ward rounds, they're all reaching for the point of care ultrasound nowadays and putting in their central lines with ultrasound. And I tell them about the days that I put in central lines without even remotely having an ultrasound. They look at me like I'm mad. But point of care ultrasound has become commonplace, and it's not an expensive intervention. And even in hospitals in various parts of our continent, there'll be some sort of ultrasound available. It requires a champion, a dedicated intervention, or at least a dedicated person sort of take that on, for example, and actually take on doing liver ultrasound. The more you do, the better you become at it. And in fact, the more the same person does it, the better the outcome is, because you have reduced inter-reader variability. The issues around alpha-fetoprotein, well, there I can't help too much because you need to have it available. But if you don't have it, at least you have ultrasound. So I hope you kind of get what I'm saying. We could go on here the whole day, quite frankly. I'm trying to say you either want to be nihilistic or you want to say, well, let's start somewhere. And I haven't covered the entire BCLC. I don't think that's the purpose of this discussion. But I'm trying to sketch a philosophy that I think you need to say, well, what can I do? And if I really want to do this, champion it, do the little bit that I can. It's better than nothing. And it's certainly better than what many people are getting at the moment. Jubal, I don't know what your view is. I mean, it's a difficult one.
Yeah, indeed, it is difficult. And especially so because like I said, most patients are presenting very late. I just looked up data that we have from the Gambia, where we looked at about 500 patients, 400 of whom had HCC, and 64% of them were presenting with multifocal tumors in their liver, with a median tumor size of 7.5 centimeters. They already had AFP levels of the median AFP level was 2,000. So what this means is that 2 out of 3 patients who are diagnosed with HCC are already presenting at a stage that is too advanced for any intervention to be meaningful. So there is no curative options for them. But we can look at this the other way around, that 67% of our patients, again, 2 out of 3, have a liver cancer caused by something that is preventable. So it's either from hepatitis B or C. So we have an effective vaccine for hepatitis B. So we could take a commitment to have a hepatitis B free generation moving forward by implementing the birth dose and the three infant doses. And we have a cure for hepatitis C now. And for those who are currently living with hepatitis B, there is an effective treatment that does reduce the risk of progressing to liver cancer and liver cirrhosis. So 2 of 3 liver cancers on the continent can actually be prevented. And what we need to do is scale up surveillance programs. Like Mark was saying, we can use ultrasound. The yield is not 100%, but it's good, and we can use it. AFP is available in certain places or not, and we can talk about its sensitivity and all of that, but it works and it can be used as a surveillance program. We just got funding from the ANRS to use ultrasound, point of care ultrasound scans, an AFP and a FibroScan to implement cirrhosis and HCC screening at a primary care level in the Gambia as a proof of concept to see whether this can actually be rolled out in non-specialist settings, where like individuals at higher risk can be routinely followed up and screened every 6 months, and we check whether that would improve the rate of early detection of liver cancer in the absence of any other sophisticated biomarkers, which we don't have access to in sub-Saharan Africa. And but we can anticipate that this could work, because like individuals can be trained to do the point of care ultrasound screening. High risk individuals can be identified and put in a surveillance program and followed up. I think the challenge we would have is that men only go to hospital when they're about to die. So having the men to subscribe to such a surveillance program will be the bottleneck. But I think this is where CSOs and other community groups can come in to raise awareness and actually encourage individuals who are at risk to sign up for some of these programs, or just to take their healthcare more importantly.
Yeah, absolutely. No, congratulations on that funding. That's that sounds very promising, and hopefully will be a successful initiative. And I think these are really, it's very encouraging to know that the bones are there for surveillance, and that it's, it is possible to scale up as long as there's a champion in place. So going to prevention and to kind of stopping the root causes of HCC. So in terms of, as Professor Sandrup, you mentioned, the birth dose is so crucial for implementing everywhere. And Dr. Ndao, you had also mentioned traditional birth attendants, which I know many play a big role, and many people seek care that way. What do you see as being needed to, I know that the barriers to implementing timely birth dose are great, but what are your thoughts on kind of getting that more available, or even other interventions, like I think offering tenofovir in the 3rd trimester, I believe, is another possibility. So just increasing, especially early childhood and mother-to-child transmission prevention efforts, and whether that uses, different types of healthcare providers. Yeah, what your thoughts are on that? Either of you can feel free to go first.
Jibril, do you want to have a go first? I'll keep on first. There we go.
Okay. I think in our setting, prevention is the only sustainable way to go. Because like Mark has said, we have very little centers of excellence across the continent where proper care can be provided for individuals with liver cancer. So access to these centers and the costs that come with some of these treatments are not affordable to most of the patients. So in order to turn the tide around around hepatocellular carcinoma, the most practical way for the continent is to emphasize on prevention. Now, this has now become a low-hanging fruit, in the sense that we have an effective vaccine that works. We have an effective prophylaxis that can prevent and even eliminate mother-to-child transmission, and the prophylaxis is safe in pregnancy and is relatively effective, affordable. And we are now having donor programs and global programs stepping in to support this. The Global Fund has now agreed to support prevention of mother-child transmission of hepatitis B by funding screening in pregnancy and prophylaxis in the second and third trimesters. Gavi has agreed to support the scale-up of birth dose vaccination in low-income countries. So these are all resources that African countries can leverage on to scale up timely birth dose of hepatitis B vaccination and prophylaxis during pregnancy. The challenges we have had in the Gambia, especially in terms of birth dose, is that even though the Gambia uses the monovalent vaccine, which is very stable at room temperature, which you don't have to worry about, like vaccine wastage by opening a vial, it's a multi-dose vial. The biggest challenge we've had is that the vaccines are not available at the place where the babies are delivered. So the vaccines are managed and administered by the public health officers, whereas the babies are delivered by the midwives. So across the continent now, we've had a significant increase in the facility delivery. So less babies are being born outside of health facilities, but the vaccines are not available at the place of birth in the health facility. And public health officers would work usual hours, Mondays to Fridays, 8 to 4 p.m., but deliveries happen at night and they happen over the weekend. And due to the demand in a certain delivery center, women who are stable are often discharged within a few hours of delivery. So they would miss the birth dose. So I think these are some of the logistical issues that needs to be addressed urgently so that birth dose administration can be scaled up on the continent. And for countries which are still, which do not have access to the monovalent hepatitis B vaccine, I think an opportunity would be to leverage support from Gavi and other donors to at least procure these so that like the vaccine can be given at birth, and then the rest of the vaccines are given within the EPI program as part of the pentavalent vaccine. But personally, I think that scaling up the timely birth dose vaccine is perhaps the most important prevention of liver cancer for Africa, and that is the way to go. Likewise, prophylaxis during pregnancy. I mean, antenatal service coverage is very high across the continent. It's more than 50% across the board. In some places, more than 90% of women would have at least one antenatal visit during the 9 months that they're pregnant. Capitalizing on this opportunity to offer hepatitis B testing for women, and then using the simplified WHO guidelines to provide prophylaxis for those who are hepatitis B positive, depending on where you are. If you have access to viral load measurement, like there's a threshold of above which women need to be started on prophylaxis during pregnancy with tenofovir. If you don't have access to viral load, the WHO has made a conditional recommendation to provide prophylaxis for all surface antigen positive pregnant women. So leveraging on these simplified guidelines and the access to pregnant women during pregnancy to provide prevention services for mother-child transmission would ultimately play in a big impact on prevention of liver cancers. There's been modeling studies that have shown that if we scale up prophylaxis during pregnancy and timely birth dose of hepatitis B vaccination, we could drastically reduce the rate of mother-child transmission, which would also consequently reduce the incidence of liver cancer that we see in early adulthood.
Yeah, absolutely. Oh, go ahead.
Yeah, so Beatrice, I absolutely agree with everything Jibril just said. I want to be maybe a little bit more provocative. And as I said recently, in the army, they say, if you're in the military, you say, "Sir, do I have permission to speak freely?" And so I'm going to ask if I have permission to speak freely. So let's just call out what needs to be said. All right. As they would say nowadays, I'm going to say the quiet part out loud. The reality is that you said, what are the burdens, or what are the barriers? The barriers to effective elimination of hepatitis B, with the foundation being vaccination as prevention, have been for the longest time our own governments, policymakers, health ministries. That has been the barrier. WHO first touted birth dose in 2008, right? Countries started adopting it, and we've had a few champion countries in Africa that have adopted it, taken it on, but the vast majority of countries have not fully adopted birth dose vaccination. And of course, we still don't have, in some countries, effective full 3-dose coverage either. Now, the practical reasons for birth dose that Jibril's just spoken about are very practical issues. We can't deny it. But there are clearly solutions. And it's about actually implementing those solutions. We know, for example, that the cold chain with respect to hepatitis B vaccine doesn't necessarily matter. All right, we know that, number one. We know that there are monovalent means of delivering the dose of vaccination. Uniject, for example, is a product that and I'm not touting Uniject, I'm just mentioning it as an option, can be used by a traditional birth attendant, a midwife outside of a facility. You see, that requires somebody to actually do that and implement it. Now, we're very grateful and very happy that Gavi and other parties have come to the party and agreed to actually fund and support birth dose vaccination. But Jibril, let's be honest. Just let's be honest. We asked Gavi in 2014 for this. It's 2024 and they've now agreed. 10 years. It took a decade. A decade. The Global Fund has just agreed. And why? It's because hepatitis B is a silent chronic infection where people are asymptomatically chronically infected. And as I always tell patients, by the time you get sick, it's probably too late. This is the problem. It's a silent disease, silent problem. There's not enough noise. Just imagine if there was a vaccine for HIV. Do you think people wouldn't move heaven and earth to have it delivered, available, that they would be climbing over mountains to give it to traditional birth dose attendants if that was the situation that was needed? Yeah, you know, so let's just say the quiet part out loud. The quiet part out loud is it's just not being done. It's happening slowly, but my goodness me, for a vaccine that has been around since the 1970s, for which somebody has won the Nobel Prize for that person whose birthday we ascribe World Hepatitis Day to, and a country such as China that not only has modeled this, but has actually shown a complete decline in their hepatitis B rates with effective mother-to-child prevention, et cetera, by just doing the simple stuff. Yet we still sit to talk about these things. I'm afraid we need to be shouting a lot louder than what we have. I'm sorry, I needed to get onto my pedestal because it drives me batty on this one. All right, so I will get off my pulpit now and climb back down.
Yeah, thank you so much. That's so important, and it's just not prioritized in the same way as HIV. Even, you know, something like COVID, which went from you know, having being discovered to having a vaccine in less than a year, and the amount of, you know, just support that has had, it's just worlds different. And these conversations, you're right, just keep repeating over and over again in different stages.
And that's why we have to be so grateful for organizations like CHIPO who fight against the odds and continue doing the work that you do. So well done. Thank you.
Thank you. Well, yeah, thank you so much. And I think, yeah, you know, hopefully just step by step. I know it's enormously frustrating in how slow it is, but so we have a couple of questions from the audience. I'd just like to bring one up. So we have an audience member. I am Cheek Boona from Mauritania. And if so, based on your experience, have you found a correlation between, oh, this is interesting, post-hepatitis B and D, hepatocellular carcinoma, as well as gender and ethnicity? And I know Delta is something that gets very little attention. So any thoughts you have on those, please feel free to share.
I'm not going to tout myself as any Hep Delta expert, but Jibril help me here. But it's a very great question, by the way, because I said Hep B is more prevalent globally, men than women. That's Hep B monoinfection. But once you bring in Delta, of course, you have more aggressive disease, your risks of cirrhosis and your incumbent risk of HCC rise dramatically. But there is a gender sex issue with Delta, where I think women are more frequently affected than men. And so once you get Delta co-infection, or not more frequently, but they sort of raise the imbalance between men and women when it comes to Hep B monoinfection with Delta. So I don't know if that answers the question, Jibril. I mean, HPV, HDV co-infection, I think women are slightly more affected than men.
Yes, that's my understanding too. Women are slightly more affected than men for the co-infection, and there are certain regions in Africa, like in Central Africa, where we have a higher prevalence of Delta compared to other areas. In terms of the risks for HCC, the assumption, well, we know that Delta does aggravate hepatitis B and progression of liver disease. So yes, it does increase the risk of liver cancer. In our cohort in the Gambia, where incidence of prevalence of Delta is very low, we didn't find it providing a much significant impact on the rate of disease progression and the incidence of liver cancer. Interestingly, what we found was amongst cirrhotic patients who were co-infected with Delta, even when they adhere to the hepatitis B treatment and they had suppression of the hepatitis B viral load, they still progress to develop liver cirrhosis if they are Delta co-infected. So that shows that, like that just shows how much Delta aggravates the whole situation and increases the risk of liver cancer. And again, now the guidelines recommend reflex testing for Delta. So everybody who's Hep B positive needs to be systematically screened for Delta. Unfortunately, access for treatment of hepatitis Delta on the continent, even globally, access is very limited. And like there are multiple reasons for this. But yes, that is the situation.
Thank you so much. Yeah, hepatitis Delta is another, very, very important issue for which there's too little diagnosis and certainly not enough treatment. We have another participant who's joining from Nigeria, who says that that many people there also don't usually check on their hepatitis B status. And I think this is just relating again to something Dr. Ndao you said before about men in particular, attending health appointments that are not necessarily when they're not necessarily feeling ill, and just if there's any strategies for advocating for people to attend. I know you said CSOs can play a role in that.
Yeah, I'm not sure there's an easy and straightforward solution to this, because already we are starting off at a very low level, in the sense that level of awareness for hepatitis B and liver cancer is very poor on the continent. And this is across the board. I mean, healthcare workers, policymakers, the general population. And second, hepatitis B is a silent killer. So most of the people who have it would not feel anything, and they would feel quite well in themselves. And so the reason, the rationale to spend half a day every 6 months in a clinic to wait to get your ultrasound done and your bloods taken so that we can do a viral load and an AFP is not very clear to them. So the perception of the risk and the importance of these surveillance programs and for them to be retained in care are not clear and upfront. So, and I think this is perhaps one of our biggest challenges. How can we raise awareness so that across the board in the general population, people understand the risks of viral hepatitis and the risks of liver cancer and the need to be retained in care through these surveillance and monitoring programs. We managed to do a fairly good job for other diseases, especially HIV infection. But I think that's because HIV has been a very dramatic illness, in the sense that those who have it, like we have all seen the pictures of, like how people progress from infection to AIDS to death. And we haven't quite seen that for hepatitis B. So the need for being retained in care and for routine surveillance and monitoring is not as clear. So I think that is what makes the difference. In our cohorts in the Gambia, we've clearly seen that those who have a better understanding of their diagnosis, of their risks, even if they're inactive hepatitis B carriers, they are often retained in care better than those who have less understanding of why they need to come back to clinic every 6 to 12 months for reassessment and surveillance. Mark?
Beatrice, I wanted to just add to the question, because I think an important issue is people not coming for follow-up and care. I mean, Gabriel's absolutely right, because, either, my gender seems to think they're invincible. But that aside, one of the other barriers that one cannot get away from is the fact that to access care and have your blood test checked and your ultrasound often comes from an out-of-pocket payment as well. And so until we actually change that factor, where people can access care that is universally funded from within the country and from the fiscus itself within the country, then that's also going to influence that, that ability to access care. There's a financial constraint. A second component to that as well has been the fact that, and I think we have to be upfront and honest about this, is perhaps up to more recently, the paradigms in which we evaluate people for care have been quite complex, and we've perhaps made it difficult for people to access treatment for hepatitis B, because we've said you need this test, that test, and this requirement X, Y, and Z. I think the WHO guidance released earlier this year has really lifted the veil on that in a big way. It's by no means perfect, but heavens, it's a hell of a big step in the right direction. It's simplified. It is structured around trying to broaden access to treatment should people require it. And also it's built into that a paradigm of you can decide on care based on your own set of resources in terms of diagnostics and testing. And so it's an attempt to broaden care. And of course, if you're seeing somebody for every 6-month visits, and you're saying to them, well, your virus is quite stable and you don't really need anything and you don't really need treatment, people also start disengaging from care. Whereas if you say to them, well, you actually need treatment because this is serious, and I'm going to put you on this tablet because it's going to prevent cancer, I think people are more likely to engage in long-term care as well, notwithstanding the financial issue. Thank you.
Yeah, absolutely. So yeah, really important points. Certainly about the need for more awareness building. I think there's numerous CSOs in different settings on the continent who are really working to try to raise awareness among communities in a variety of ways and get it to the level of HIV in terms of the public consciousness slowly. But and then certainly, yeah, the complexity of the disease, definitely the WHO guidelines and new recommendations can hopefully help with making it just clearer, and because there's a tremendous amount of confusion, I think, on multiple sides with hepatitis B. And then the financial burden for sure is, of course, absolutely necessary. I think there's been some strides in Ghana recently to include more hepatitis B care cascade in the health insurance scheme. So hopefully that can be, replicated and scaled up. So we are just almost to the top of the hour. So I just want to say sincerely, thank you both so much. This has been such a robust discussion, and we really appreciate all of your insights and hope, to continue to drive this forward, and especially hopefully preventing HCC from happening to begin with. So thank you both so much. I just want to make some closing remarks. Shreya, would you mind just sharing the screen or the slide just quickly? Thank you so much. And thank you to everyone who attended today's webinar. It looks like we had broad attendance from multiple different countries. So we so appreciate you being here. And we hope that you found this informative and valuable, and are able to, take some of these thoughts forward in your life and work. And we encourage you to visit CHIPO's website to learn more if you're interested in joining the coalition and becoming a member, you can feel free to reach out to me, and I'll send the CHIPO website and and my email address in an email to all registrants as well after the conclusion of the webinar, as well as our social media links so that you can follow us there. So thank you so much again to both of our panelists and to everyone for joining. We really appreciate it. And I hope you have a wonderful rest of the evening, and safe travels if you are
Thank you.
onward.
Thank you.
Thank you so much.
Thank you. Yeah.
Okay, take care.
Bye.